Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will be discussing testicular lesions for the core exam with a specific focus on testicular tumors and other testicular pathologies. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com. I have also recently added several additional podcast transcriptions on prior podcast episodes to the study guides on a few of my earlier episodes for which I did not initially make a study guide. So if you are trying to download and collect all of the study guides, go ahead and check those out at theradiologyreview.com. I also have an announcement that the Radiology Review Journal that some of you may have seen at theradiologyreview.com is now being renamed the Radiology Review Insider. That is a collection of some interesting and often educational articles themed about radiology and medicine that you can check out if you have a few minutes and want to perhaps learn something new outside of board preparation. Without further ado, let's get into the questions and answers for this episode. First question: true or false? Most testicular tumors are germ cell tumors. The answer here is true. Up to 95% of testicular tumors are germ cell tumors, with roughly half of these being seminomas, which makes a seminoma the most common testicular tumor. Testicular germ cell tumors are the most common non-hematological malignancy in young male adults. Next, what are classic risk factors for development of testicular cancer? Risk factors for development of testicular cancer include cryptorchidism, Klinefelter syndrome, chronic orchitis, gonadal dysgenesis, and possibly testicular microlithiasis. I would be familiar with each of these risk factors for the core exam, and let's go ahead and move on to the next question. What testicular tumors are most common in the first decade of life? In the first decade of life, the most common testicular tumors are teratomas and yolk sac tumors. Next, what testicular tumors are most common in elderly males? The answers I am looking for are testicular lymphoma and spermatocytic seminoma. So remember, in the first decade of life, teratomas and yolk sac tumors are the most common, and in elderly males, testicular lymphoma and spermatocytic seminoma are most common. Next, what is the difference between classic seminoma and spermatocytic seminoma? Let's first talk about a classic seminoma. A classic, or you could consider garden variety seminoma, looks like a homogeneous hypoechoic on ultrasound, round intratesticular mass with smooth margins that often is T2 hypointense on MRI. These are most common in adults around the fourth decade. A spermatocytic seminoma accounts for only about 5% of all seminomas, so they are rare. And they present, as we said on the prior question, in much older males. Spermatocytic seminomas have low metastatic potential. These cells look like secondary spermatids, and hence the name. Both classic and spermatocytic seminoma are usually unilateral. Both are also not associated classically with elevated alpha-fetoprotein and may have a slight elevation of beta-Hcg. Next question. What testicular tumor is most common in teenage males? The answer I'm looking for here is a choriocarcinoma. Next question. True or false? Orchiopexy reduces cancer risk in the setting of cryptorchidism. The answer here is false. Cryptorchidism is associated with an increased risk of developing testicular cancer, and this risk in both testicles persists despite orchiopexy. That is something that is important to remember because it is easily tested on the core exam. Next, true or false? Seminomas can arise outside of the testicles. The answer is true. The anterior mediastinum is the most common site of extratesticular seminoma. Next, what is the prognosis of a seminoma? Seminomas generally have a favorable prognosis as they respond very well to therapy that includes radiation. Next question. What are names of various non-seminomatous germ cell tumors of the testicle? Non-seminomatous germ cell tumors include choriocarcinomas, teratomas, yolk sac tumors, and mixed germ cell tumors. On imaging, these non-seminomatous germ cell tumors tend to appear more heterogeneous and calcified, and often present in an even younger age group, such as teenagers. Note that unlike the majority of malignancies that are most prevalent in older individuals, testicular tumors are actually most prevalent in teenagers and young adults. Next question. True or false? Testicular choriocarcinomas most commonly metastasize through the lymphatics. The answer is false. A choriocarcinoma most commonly demonstrates hematogenous metastases, whereas most other testicular tumors show lymphatic spread to the retroperitoneum, specifically or classically at the level of the renal hilum first. Note that this is a somewhat unique pattern of spread, which is in contrast to the nodal spread of things like prostate cancer that usually starts in the pelvis and extends superiorly. Testicular cancer, excluding choriocarcinoma that most commonly spreads hematogenously, may first spread to the extrapelvic retroperitoneum. Next question. If ultrasound shows multiple hypoechoic testicular masses, this is most common for what entity? The answer I am looking for is testicular lymphoma. Testicular lymphoma should be considered if multiple hypoechoic masses are seen within the testicle. Testicular lymphoma is notable in cases of systemic lymphoma because the blood-testis barrier can prevent systemic therapy from reaching and treating sites of testicular lymphoma. On an FDG PET-CT scan for lymphoma, one should not forget to evaluate the scrotum for any hypermetabolic testicular masses that could represent testicular lymphoma or another testicular malignancy. If testicular lymphoma is present, orchiectomy may be indicated given the difficulty in treating these testicular masses with chemotherapy due to the blood-testis barrier. Next question. True or false? Testicular tumors can theoretically spontaneously regress. The answer here is true. Although management can be controversial, one can have a burned out testicular tumor that often presents as a densely calcified lesion in older males, or simply only a dense calcification. It is difficult to confirm on imaging, however, whether viable tumor may still be present, and regression is sometimes only partial. Next question. What is the top cause of acute scrotal pain in adults? The answer I am looking for is epididymitis. Causes of epididymitis include gonorrhea and chlamydia infections or an E. coli infection. Imaging findings on ultrasound include epididymal head enlargement and increased vascular flow to the epididymis. Next, what is a classic cause of isolated orchitis without coexisting epididymitis? The answer I am looking for is mumps. Mumps, M-U-M-P-S, mumps classically can cause orchitis without associated epididymitis. Next, true or false? Testicular fracture typically requires surgery, whereas testicular rupture does not. The answer here is false. Testicular fracture often can be managed non-surgically, whereas testicular rupture often requires surgery. Next question. What are other key differences between a testicular fracture and a testicular rupture? Let's first talk about testicular rupture. A testicular rupture has a disrupted tunica albuginea as well as a poorly defined testicular outline with a heterogeneous testicle. Compare that to a testicular fracture, which has an intact tunica albuginea, and the testicle demonstrates a hypoechoic linear band through the testicle and maintains a well-delineated testicular outline. So testicular rupture includes a disrupted tunica albuginea with poorly defined testicular outlines, and a testicular fracture has an intact tunica albuginea and a well-delineated testicular outline, and a testicular rupture often requires surgery, whereas a testicular fracture is often managed non-surgically. Next, what are common imaging findings of testicular torsion on ultrasound? Imaging findings of testicular torsion include absent or decreased blood flow within the affected testicle compared to the contralateral testicle, as well as asymmetric testicular enlargement and a more hypoechoic appearance of the torsed testicle. Next question. What is the so-called bell clapper deformity? The bell clapper deformity is an unusually high attachment of the tunica vaginalis that allows increased mobility and twisting of the testicle and raises the risk of developing testicular torsion. As the bell clapper deformity usually involves both testicles, surgical treatment involves orchiopexy and should be performed on both sides. Next, what are some of the classic imaging features of a testicular epidermoid cyst? Classic imaging features of a testicular epidermoid cyst include an onion skin appearance of the mass that tends to show less blood flow than the normal testicle. Note that testicular epidermoid cysts are characteristically benign. Next question. What is a leading cause of calcification of the vas deferens? The answer I am looking for is diabetes. Diabetes is a classic cause of a calcified vas deferens. Next, what is the classic cause of tubular ectasia of the rete testes? The answer I am looking for is partial or complete obliteration of the efferent ducts, E-F-F-E-R-E-N-T, efferent ducts that causes cystic dilation of the rete testes about the mediastinum testes. This is a benign finding. Next, on a board exam, if they present you with a scenario of bilateral Sertoli-Leydig cell tumors of the testicle, what underlying disease entities should you consider? The answer I am looking for here is Poitz-Jeghers syndrome. In general, Poitz-Jeghers syndrome is high yield for the core exam and includes things like multiple colonic polyps and freckling of the lips and face. Next, what testicular tumors are associated with an elevation in Hcg? Testicular tumors that are associated with an elevated Hcg level are the testicular omas, meaning seminoma and choriocarcinoma. Next question. What testicular tumors are associated with elevated levels of alpha-fetoprotein? The answer I am looking for is testicular mixed germ cell and yolk sac tumors. These are associated with high levels of AFP, whereas seminoma and choriocarcinoma are associated with elevated levels of Hcg. Next question. What is the triad of Zinner syndrome? That is Zinner, Zinner syndrome. The classic triad of Zinner syndrome is 1. Unilateral renal agenesis, 2. Ipsilateral seminal vesicle cyst, and 3. Obstruction of the ejaculatory duct. One should consider Zinner syndrome when you are presented with a history of male infertility as well as renal agenesis. Next question. What are common causes of obstructive male infertility? Common causes of obstructive male infertility that I would remember, especially for the core exam, include cystic fibrosis with bilateral absence of the vas deferens, Zinner syndrome, which we just discussed, as well as other causes of ejaculatory duct obstruction to include entities like prostatic cysts. Next, what are common causes of non-obstructive male infertility? The first potential cause of non-obstructive male infertility that I would remember for board exams is a varicocele. Also remember things like erectile dysfunction, anabolic steroid use, and cryptorchidism, increased risk of non-obstructive male infertility. Next question, is a varicocele more common on the right or on the left? The answer here is that a varicocele is more common on the left side. Next, if you are presented with a unilateral right-sided varicocele, what underlying process must you consider? The answer I am looking for is that in the setting of a unilateral right-sided varicocele, you must consider the possibility that there is something like bulky retroperitoneal lymphadenopathy or another retroperitoneal mass that causes right gonadal vein compression or obstruction. Having a right-sided varicocele can be a presenting sign of malignancy in the retroperitoneal space and can be seen with metastatic cancers to include testicular cancers. Last and final question for this episode. If you are presented with a paratesticular mass in a young boy, what classic tumor should be considered first? The answer I am looking for is a rhabdomyosarcoma, as this can present as a paratesticular mass. Note that the botryoid variant of rhabdomyosarcoma has a characteristic bunch of grapes appearance and is often tested on board exams because of that characteristic and unique appearance. So if you see a paratesticular mass that looks like a bunch of grapes, you should consider that this could be a botryoid, botryoid, variant of a rhabdomyosarcoma. Remember that a rhabdomyosarcoma is the most common bladder cancer in young boys. That concludes this episode. I hope these questions and answers are helpful for many of you. If you would like to review the content of this episode in written form, please download the free study guide on my website, theradiologyreview.com. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.